Okay, so I actually am a cardiologist. I wasn't really intended to be this expert in women's health, but when you are a female in a field where the participation of females in the field is as low as it is in cardiology, by default, you have to be the expert because no one else is going to take up that banner. So it turns out that cardiology, we have the lowest participation for females compared to any other specialty. And that's a real big problem because, in fact, as you were alluding to, Dr. Susan, women make up more than 50% of the population because remember, we live longer, right? So we have a longer life expectancy. I love this tree. It's the tree of life. And like in the center of that tree of life is the female because we bring life, we sustain life, we encourage life, we support life, and our lives are long. Women outlive men by 3 to 5 years, and that's even in all societies, unless there is an at-risk population during childbirth, which certainly still happens in certain populations. But here's our reality, right? We live a long life. We go through a long period of, maturation, and we're going to see that there's a gender gap, there's a racial gap, and we're going to talk about some of those things. So what is menopause? Natural menopause occurs when you stop having regular periods without any other, trauma or surgery. When it occurs naturally, it normally occurs between the ages of 45 and 55 years of age. And it occurs when there's depletion of the ovarian follicles. And so that you can no longer, harvest an egg to be released. And this leads to low estrogens. And when your estrogens and your ovarian hormones drop because the ovaries are no longer producing them, then the hormones that are coming from the brain that stimulate the ovaries, they go up because when the ovaries quit producing, the brain is trying to tell the ovaries with these chemicals like FSH and LH to please make more estrogen. But when that feedback loop is interrupted, the pituitary hormones go up. And those hormones, FSH and LH, are some of the hormones that we can measure to determine where you are in your menopausal journey. Premature menopause occurs when someone has menopause before the age of 40. It's also called primary ovarian failure. And this occurs in, maybe 2 to 6% of the population. And it's associated with excess cardiovascular risk, bone loss, and cognitive functional decline. Because in fact, these hormones that we bathe our bodies in, our female hormones, they actually protect us from cardiovascular disease and they protect our bones big time. So anybody under 40 that goes through menopause, it's premature. Early menopause is when you have menopause between the ages of 40 and 45, okay? If you've had a hysterectomy, they've taken out at least your uterus, okay? Sometimes they leave your ovaries. If they leave your ovaries, which they do if they do a hysterectomy when you are young, so less than 45 or 50. And certainly there's usually a conversation with the patient about whether or not their risk for ovarian cancer is significant. But mostly we try to leave the ovaries in, and so we do a partial hysterectomy. Menopause may happen when you take out loss of ovarian function may happen, obviously, when they take out your ovaries. So if you take out your ovaries, you automatically are in menopause. So that's why we try not to take out the ovaries, because we want to leave the body with the production of estrogen for as long as we can, okay? Unless there's some excess risk for ovarian cancer. But in fact, for people that have had a hysterectomy, it's really hard to tell if you're in menopause or not. So in fact, in the Women's Health Initiative, which is this big study looking at postmenopausal status, only 2/3 of women that have had a hysterectomy could tell if they were in menopause or not because they quit having periods because they quit having a uterus. So it's sometimes hard to tell, and we have to use the chemicals. So here's what the natural stages of reproductive aging look like. At 0, that's the time when you have your last menstrual period, okay? And you can see that before you have your last menstrual period, you've had low estrogen production during the years, maybe 5 to even 10 years before you have menopause. And during this period, you are making less follicles. Therefore, you're making less, you're dropping less, estrogen levels drop really low. And this is a time when your Müllerian hormone levels drop really low. And it makes it very difficult to become pregnant during these premenopausal years, okay? During these premenopausal years, people start having symptoms. And they start having symptoms because as their estrogen levels fall, they start to feel these symptoms of menopause. And so people have irregular periods, their blood pressure may go up, their cholesterol starts to rise, their sense of well-being declines, they may gain weight, and they start being at more risk for having heart disease. After menopause, the time clock clicks. And when you have menopause, you start having symptoms of low estrogen. And these symptoms include irritability, emotional issues, sleep difficulties, and hot flashes. And silently during this period, people start having increasing risks of heart disease and bone loss. So you lose bone the first 2 years after menopause significantly. So this is why it's super important before menopause and before actually age 30 that you really need to have as highest bone strength that you can, which means you need to exercise and you need to lift some weights. So there are factors that influence the natural menopause, and these include race and ethnicity. There are reproductive issues that can make you have more risk of having early or late menopause. The premenopausal cardiovascular health is actually really important. And your diet, your alcohol consumption, and how much physical activity you get can affect menopausal timing. Smoking, and certainly weight before menopause and your body mass index can affect it. And the most important thing I find is it's genetics. So what happens during menopause? So it's a dynamic period of life where estrogen starts to fall and your follicle stimulating hormone levels from your brain start to rise. Your menstrual cycles change, you become less frequent, you may skip a period, and you start noticing these menopausal symptoms, which we call vasomotor symptoms, which are just hot flashes. There may be abnormal bleeding during this period, and you may have light periods, you may have heavy periods, you may be spotting. And sometimes the doctors will intervene during this period and put you on some hormones. If they put you on hormones to regulate your periods, you may just stop having periods altogether. And I think that's a very common pattern of treatment for women during this period. But some women have IUDs. And so these IUDs make you not have your period. So like a hysterectomy, you don't know when you've gone through menopause. So hot flashes are the main primary, symptoms that women have. And about 80 to 85% of women experience these vasomotor symptoms. These symptoms can last up to 10 years, and they can be variable and they can be different in different periods. Most women have early onset vasomotor symptoms that start to occur before you go through menopause and decline after menopause. There are people that have onset of symptoms around their last menstrual cycle and decline over time. But there's a good percentage of people that have a persistent high frequency of those vasomotor symptoms, and these people need treatment. There are some women that just sail through menopause and have no symptoms. These are women that are unique. Mostly people complain of sleep disturbances. Some people have anxiety. I had funny story in that I have a busy job that's filled with risk, and I didn't have trouble making decisions when I was younger. And after age 50, I started worrying more, and I would wake up. So I experienced a little bit of anxiety. And when I brought this up to my male colleague, I didn't really think of it as being perimenopausal anxiety. And neither did he. It's funny because, in fact, he said, welcome to being a fully formed human, in that maybe I'm just more sensitive to the consequences of my job because I see the full impact of it. And so I may have thought it was just growing older and being more sensitive to the fact that our job carries a lot of risk, and I worried more. But I do think that the hormonal decline that I was experiencing really contributed to this feeling. And I don't look back on this period of my life and think it was a bad thing. I actually think it's kind of good if you're worried more or care more, or you're more worried about things that you didn't worry about. It made me a better doctor. Certainly, certain patients complain of cognitive performance decline, but it isn't really true that people lose real IQ during this period. You haven't lost it, it's there. You just may not be sleeping well, and you may be worrying more, but you're still a competent human. Certainly there are changes in genitourinary health and sexual problems that people complain of. But as a cardiologist, I'm much more concerned at this point about the real risks associated with life expectancy and what we can do about it. Because, in fact, women, as they age, they really don't have any significant cardiovascular risk before they go through menopause. So, in fact, the whole hormonal milieu of being a female in reproductive years actually is very protective against the development of cardiovascular risk factors. So, in fact, I was on duty last night. I didn't know I was on call until they called me and said there was a woman in the emergency room having chest pain, and they were worried about her EKG and could I come? And I actually was on the way walking and talking to the doctor in the emergency room. And first question I asked is, how old is she? Because how old she is really dictates partly what her risk group is. So if women are under 50, mostly they're premenopausal. And if they're premenopausal and they haven't smoked and they don't have type 1 diabetes, the likelihood that they have chest pain at rest is related to a blockage in their arteries is kind of small. So for the patient last night, she was 68, so she was clearly postmenopausal. And she had a lot of cardiovascular risk factors like these on the list. But these cardiovascular risk factors, they accumulate after or during the menopausal period. So in fact, the blood pressure goes up, most importantly, because withdrawal of estrogen leads to a direct effect on the vasculature that leads to increasing blood pressure. It turns out that estrogen in its natural form, when produced by the body, is one of the most potent dilators of the blood vessels in the body. And when you lose that blood vessel dilator, then the other blood vessel constrictor chemicals have more free range and have more impact on your blood pressure. So there are women that go through menopause and have no elevation of the blood pressure, but most women's blood pressure goes up in their 50s and continues to climb as they age, such that I'm a big fan of talking about blood pressure. You may be able to find out that it's one of my soapbox topics. And the reason is it's the most important risk factor for heart disease. And when I say heart disease, I'm talking about arterial blockage and plaque. But arterial plaque and blockage occur most commonly as a risk factor from high blood pressure. And high blood pressure begins in the menopause in most women. In some women that are at higher risk, like African American women, they start getting high blood pressure in their 40s. Some people get it in their 30s. And this is a dramatic reason why these groups get cardiovascular disease earlier and at higher rates and at higher risk than in other groups. So blood pressure is super important to our overall cardiovascular health. And it goes up during menopause. The other thing that goes up during menopause is cholesterol. And when we talk about cholesterol, and if you look at your cholesterol profile, it's got all these chemicals in it. I've really taken to just getting people to concentrate on their LDL cholesterol. LDL is the lousy cholesterol. It's the bad cholesterol that creates the milieu that makes you make plaque. It's like the roux in the gumbo that makes you make plaque. Okay? And if you're making gumbo, which you don't want to make because gumbo is the cholesterol plaques in your arteries, you got to stop making the cholesterol. Okay? You need to control your blood pressure as well, but you really got to get your LDL really low. In fact, the human is pretty much the only organism that's walking around on the planet making high levels of cholesterol. And in fact, we're the only animal that makes, these plaques. And if you get the cholesterol levels down to as low as 50, you probably stop making plaque. So that's kind of the new goal for LDL treatment for patients with established vascular disease. And we're dropping the target. Used to be 70, now it's kind of 55. But certainly most people, hardly anyone is walking around with an LDL cholesterol below 100 after menopause. Certainly there are children, they're walking around with low LDL, but as we age, our LDL goes up for many reasons. One, we use less of our cholesterol because we're not building brain and neuro tissues, and we probably make more as well. And that contributes to why we get plaque as we age. The other thing that happens when we go through menopause is we develop insulin resistance syndrome or metabolic syndrome. And what that means is our cells are no longer responsive to the action of insulin, and our insulin levels start to climb. And as these things happen, we are experiencing weight gain, our glucoses go up, our A1C, which is a marker of 30-day glucose control, goes up. We start to get fatty liver, and we start to interfere with cellular metabolism. And when that happens, we start increasing our risk for cardiovascular disease. During this time, certainly we gain weight. Our diets may become more laden with calories, and we exercise less. And so the motivation to exercise may go down. Women during this period of life are bombarded by work, family dynamics such that we're caring for our elderly family members while we're still supporting our children and our husbands. Most of us are still working, and it adds to less time in the day to actually exercise. We become more fatigued, and certainly one of the biggest contributors to cardiovascular ill health is cigarette smoking, but it's continued to decline. Unfortunately, this vaping epidemic's got us worried because young people had stopped smoking and now they're starting to vape. So now we're stuck with, during this journey of menopause, what are we supposed to do? How are we supposed to live? Should we take hormones? When is it safe to take hormones? And what does the data say? So on this very complicated slide, it reminds us of like some important studies that happened about 20 years ago. So we knew that people went through menopause and that menopause increased our risk of, all kinds of bad things, diabetes, heart disease, and it became kind of a kind of cliche. Maybe we should treat these women with hormones, and it became really the pattern. During the 1980s and 90s, it became very commonplace that when women went through menopause, that they were put on hormones. And these hormones were thought to protect women against the ravages of menopause, and bone loss and cognitive decline and heart disease. And so a lot of data was analyzed as women aged. And these were just epidemiologic, follow the woman through her life kinds of surveys, and they led to the belief that hormones would benefit women. So in the late 90s, they started doing large-scale randomized controlled clinical trials on postmenopausal women. Unfortunately, when they ran these trials, they ran the trials in women who had already finished menopause and were distant from their last menstrual cycle by at least 10 years. So when you randomize women who've been without hormones for 10 years, they're not the same women as if you randomize the women as they went through menopause. And this is a very important consideration because, in fact, women need hormones not 10 years after they go through menopause, but as they're going through menopause, because hormones are the best treatment for vasomotor symptoms such as hot flashes. So to treat women for postmenopausal prevention 10 years after menopause doesn't really sit with how we would take care of people clinically. The reason they did these trials in this manner is they didn't want people to enroll and be randomized to a treatment group, such as not receiving hormones, and have women drop out of the trial, because that would hurt the clinical trial outcomes. Because if people drop out of their treatment group, then they're not really getting the full benefit of being in the trial. So these trials were designed to have a complete trial, but they really didn't answer the question that really we needed answered, which is, as women go through menopause, should they be treated with hormones? And if they are, do they do better than compared to those women who didn't get treatment? So in this big trial, they actually treated older women who were without hormones for 10 years. And during that 10-year period, these women laid down plaque. And when you lay down plaque and then you give hormones to these women later, they showed that it increased the risk of heart attack, because all hormones increase your risk of clotting because they make your blood a little bit thicker. So all hormones given to people after, senescence or menopause increase your risk small for stroke, for venous clotting, and for heart disease. So if women want to take hormones, they need to take hormones because they're having symptoms during the menopausal period. And you have to do an evaluation on that woman to see if she's still in a low cardiovascular risk group. Now, I do this all the time. And most women that go through menopause early, in that early period of menopause after age 52, are still in the low risk cardiovascular group. And we routinely say it's okay. And the usual dictum now for hormone replacement therapy is that you should take the smallest dose of hormone for the shortest amount of time and then be reassessed over a few year period. So menopausal hormone therapy, not all women need treatment for menopausal symptoms, but women that have symptoms of menopause with hot flashes and sleep deprivation, they can safely take hormones. And they fall into two categories. Women that have had a hysterectomy, they need only estrogen, because progesterone is given to women that have to take, that want to take estrogen for the reliefs of these vasomotor symptoms, but you have to take progesterone to prevent uterine cancer. So if you don't have a uterus, you don't need the progestin, and you can only take estrogen. And the best delivery mechanism for the estrogen in these postmenopausal women is really probably transdermal or through the patch, because hormones that are delivered through the gut, through the oral route, go through the liver, and it's thought that these hormones increase the risk of clotting, because it increases the clotting factor production by the liver due to the oral administration of estrogen. But if you give estrogen transdermally through a patch, it is thought that it may be safer. Certainly, hormones are beneficial for those women with osteoporosis And it's a very important consideration. In fact, I have a conversation maybe once a week with women who are going through menopause that have really profound bone loss. And really, estrogen is the best treatment for that bone loss, even compared to all the other treatments we use for osteoporosis. So if you can take estrogen and your cardiovascular risks are low, I'm game. Let them take the estrogen. But estrogen, I want you to know, is the most effective treatment for hot flashes. Other kinds of other treatments that do not entail estrogen use can be tried, particularly for those that have a history of cancer or for those that are at high cardiovascular risk or have other weird things. So other chemicals can be helpful, and they've been studied in women that are actually going through cancer treatment. And those women have been randomized to these antidepressants, and they're actually quite effective. I use the gabapentinoids now a lot because it really helps with sleep. Some people use clonidine. I don't really love clonidine because it makes people dry mouthed and dry eyed. And there are other kind of techniques, but people swear by, and I swear by this, I swear by the very best way to get through menopause is to exercise. Because it induces your endorphins. It improves your cognitives. It makes you feel better. I will say that before menopause, I exercise, because I wanted to be healthy. But after menopause, I exercise to maintain my mental state. I find that on the days that I don't feel like exercising because I feel kind of lackadaisical or fatigued, those are the days I need it the most, because if I don't exercise that day, I won't get better. So I find that that is a very helpful strategy. Others use cognitive behavioral therapy, hypnosis, and mindfulness, and stress reduction. Yoga helps. So lots of things can help, but I'm a big proponent of exercise. I'm going to go through these because exercise actually helps with primary prevention for cardiovascular events. It reduces your risk of heart attacks. It reduces your blood pressure. It improves all your cardiovascular risk factors. And if you're interested in knowing how to improve your sleep, you've seen these sleep schedules where, stay on a strict sleep schedule. Don't sleep in the middle of the day. Avoid caffeines or screen time before you go to bed. Make sure your room is really cool. I love a fan right by me. In fact, I have a fan clipped to the table next to my bed, so I get the full blast of the fan on me. I certainly do think that exercising regularly are super helpful. Certainly don't eat a large meal close to bedtime, and don't drink caffeine after 4 p.m. Alcohol is a serious detriment to your sleep. It interferes with your sleep. It is not good or healthy for long-term cognitive health. And so I'm kind of become quite negative about alcohol long-term for health. Certainly we need to know that these are the people that cannot take hormone replacement therapy. If you've had a history of breast cancer, if you're at high risk for breast cancer, if you've had other estrogen-based cancers, ovarian, uterine, if you've had a history of blood clotting, if you've had a deep vein thrombosis or a pulmonary embolism, if you have a family history of clotting disorder, most common clotting disorder is factor V Leiden, then you should not, I repeat, you should not take hormones. And that means estrogen and testosterone. There's a big group of women and men particularly that are eager participants in taking testosterone. Testosterone is a hormone or maybe worse than estrogen, that induces clotting. So it needs to be thought through before you take any hormone. Am I at risk of clotting? Do I have any arterial blockages? Do I have chronic liver disease? Do I have migraine? Or am I at increased risk of stroke because I have uncontrolled blood pressure or terrible cholesterol? These conditions should make any doctor or any patient very hesitant to take an estrogen by any means. So we've talked about these hormone replacement trials and the risk, and the slides are available for you to review. But I wanted to open up the question period because it brings up a better ability to, dive deeper into these questions and get to some of the answers that are making people worried out there, because it's confusing. So I'm going to turn the slides back to you guys, and we can just talk and answer questions to people that are sending things into the chat room. Is that okay?